Hello, my name is Romayne Gallagher. I'm a physician at Providence Healthcare and I do palliative care. I'm going to talk today about what palliative care is, how it works. I'm also going to talk about patient rights, and along the way we'll talk a little bit about physician-assisted death. When people think about palliative care, they often have notions that are based on a lot of myths. For example, that they don't really see palliative care until late in their illness, and that means if they see them, death must be right around the corner. Some people think it's a place where you die. Many people think that you've seen palliative care because nothing else can be done for the disease. Many people think that this is it. From now on, they're going to be drugged and confused. People often worry that the medications we use may cause you to die sooner. And last but a big one is that you have to choose between continuing to fight the disease and accepting palliative care. And many people are not aware that palliative care can be used in any illness. So I'm going to talk a little bit about what palliative care actually is. This is probably the latest definition of it, and it is that palliative care provides an added layer of support for relief of pain, symptoms, and stress for people with serious illness and their families. Palliative care, since its start, has affirmed life and regards dying as a natural process of life. We have an approach to care that's now backed up by medical evidence. We spend a lot of time controlling symptoms, be these physical, psychological. We also treat the whole person. So in other words, your body, mind, and spirit, or body, mind, and soul. We see that we also care for the family as well as the patient, and we see ourselves supporting survivors after the death. Now, a lot of people get confused because people use terms and they're not really sure what they mean. And here we have a diagram showing palliative care, end-of-life care, and terminal care. Palliative care is the overall umbrella, really. It's the whole sort of philosophy and approach to care. It can be done any time from diagnosis onwards. End-of-life care tends to focus on the last weeks to months of life when the person is sort of obviously dying. And terminal care is really the last hours to days of life. So I hope that sorts some of these out. They are different things, but they all fall under the umbrella of palliative care. There have been a lot of studies asking people with serious illness what's important to them and what they need. And just about all the studies, like this one from 1999, note that people want their pain controlled, they want shortness of breath and other symptoms controlled. They want to avoid inappropriate prolongation of the dying process. Meaning, don't do a lot of things to me that won't prolong my living, but will just prolong my dying. Sometimes that's really hard balance to strike and very difficult to work out. And it might be different for each person. A lot of people want to have a sense of control over what's going on. So they want to be involved in decision making. They want to decide where they want to spend their final months or weeks, and they want to understand what's happening to them. People want to relieve burdens on family. They understand that by its very nature, it's going to be hard on everybody, but they don't want to burden people with difficult care, etc. And they also want to complete and strengthen relationships. In other words, people are still alive when they're dying, and you live up till the moment you die. And so the chance to seek forgiveness or to say important things to people is still very much so. And many people continue to grow during this difficult period and actually find that they achieve some excellent quality of life, and some very important things are said and done in this time. If you ask family caregivers what they need, they're more interested in the mechanics of giving care. In other words, they want their loved ones' wishes honored, and they want to be involved in decision processes, especially if it's going to involve their participation. But they're also looking for the practical help, like how are they going to get the person to appointments, how are they going to do personal care, information about what's happening so that they can prepare themselves, someone to call when there's problems, and someone that they can follow up with after their loved one has died. So when palliative care becomes involved with patients in the hospital and community, the palliative care team approach was associated with significant improvements in people's symptom management, so they had less pain, less nausea, vomiting, shortness of breath. People and their families were more satisfied with care. We actually reduced the length of time that people spend in the hospital, and we also reduce in-hospital deaths. One thing that has generally come up is that people would sooner not die in the hospital, and so it's often important for people to either get to a facility that's more home-like, such as a hospice or some other place, or to die at home. The problem is that oftentimes palliative care comes at a time when people say, well, it was too late. I wish we could have seen you people much earlier, or I feel like we didn't switch to this approach until late in the game. And if people perceive it's too late, they often have much less satisfaction, more unmet needs, less confidence, and more concerns about coordination. So it's really important that people get access to this approach to care and this philosophy early, and much earlier in their illness than has been done in the past. This actually inspired people to begin to do research on introducing palliative care early. And this is one of the most well-known early palliative care studies that we have. And what it involved is 151 people newly diagnosed with metastatic lung cancer. In other words, the lung cancer had spread beyond the original tumor in the lung. And they randomized, in other words, randomly selected people to either receive usual care or to receive palliative care up front with sort of additional visits alongside the visits with their oncologists. The early palliative care group at the end of this time rated that they had a better quality of life, they had fewer depressive symptoms, and most interestingly, they lived 2.7 months longer than the people who just had usual care. So it's very interesting because they did not have more treatment of their disease. In fact, some of them may have chosen to have less treatment. So what did the palliative care team do that led to this 2.7 month survival? So there was a secondary study looking at the visits, what happened when patients went to visit the oncologist and what happened when they went to visit the palliative care team. And what they found is that the oncologist, of course, asked them about their symptoms, talked about where the status of their cancer, and they talked about what further treatment could be done and the complications. When people visited the palliative care team member, they talked about symptoms, but they talked about coping with the illness and sort of understanding where you were at in terms of how the illness was going and how close you were to the end of your life. Sort of being aware of where you are on that continuum from the beginning of the illness to the end of the illness. So these differences made a significant difference in survival, which is very interesting. What we do know from these studies, of which there have now been a number of them, is that the earlier one sees palliative care, the earlier you can start to benefit from this. So I hope you can understand that the myth of you die sooner if you get palliative care, or if you give up trying to beat the illness and accept palliative care, that's not true. And there's been more studies now looking at how we should incorporate palliative care into chronic disease management, how we incorporate it into cancer management, so that people can receive palliative care earlier. So who provides palliative care? Well, it sort of depends on where you live and the complexity of your situation. So in small towns, this can be done by the family doctor and the community nurse, who may or may not have extra training in palliative care. In cases where things are more complex, the symptoms are harder to manage, they may involve people with some special training in palliative care. And of course, in big centers, we have palliative care units and so on. And we have physicians who are specially trained in palliative care. We also have nurses with special training in palliative care, social workers and spiritual care providers, and who becomes part of the team that helps the patient and family depends on a number of factors. Now, here's some data from our palliative care use in British Columbia dating back to 2012. In 2012, there were 31,000 deaths, and about 11% of people die a sudden death due to a catastrophic illness like a severe heart attack or stroke or an accident, etc. They're not likely to benefit from palliative care. So when you subtract those away, you have 89% of people who could benefit from palliative care. 20% of those people were seen in specialist palliative care programs in large centers. 31% were identified as palliative care patients and received palliative care likely from their family doctor or in the by the primary care providers where they lived. There still was 38% of people, that's over 1/3, who could have benefited from palliative care but did not, we cannot find any record of them receiving anything that we would call palliative care. So we still have a long way to go. It's estimated that about 2% of our population dies each year, but this uses an enormous amount of resources. In other words, 38% of our healthcare spending goes towards managing the last year of life. So you can see how important this is for looking at who receives palliative care, because we have some evidence that if people receive palliative care earlier, they tend to have fewer unnecessary tests and treatments, and they're more aware of what can benefit them and if they know how long they're going to live, they're better at deciding about treatments that may or may not help them. So I hope I've convinced you that not everyone gets palliative care, and that's part of the problem, is that it's not integrated into all serious illness care yet. And there's a number of barriers towards getting palliative care into all healthcare. For one, we tend to be a death-denying society, so people don't really want to think about palliative care or think about the end of their life, and they figure if they just put up a wall against that maybe it might help them. I hope I might have convinced you that in fact breaking down that wall and accepting palliative care is actually going to help you put off death much longer. The other problem is that healthcare providers also find this difficult to deal with. And we tend to have, one of the reasons why we may have gone into healthcare is because we have high death anxiety or concern about that. And here we are supposed to be the people talking to patients and families. The other big thing is that sometimes healthcare providers are not aware of what palliative care can do to help their patients and the family. And the same could be said for patients as well. There's a public lack of awareness about it. The other factor is health literacy. Oftentimes people aren't sure how to negotiate the system and how to find out information. And it should be built in so that everybody kind of receives this care by default. And then, of course, some of the other problems are around decision making and so on, and the difficulties with this. And we're working on improving all of those things. I wanted to also dispel some myths about some of the medications that we use in palliative care, because this also is a barrier to people receiving the care that can best help them. So many people, if they have pain or shortness of breath, will be encouraged to take medications such as morphine, hydromorphone, fentanyl, or oxycodone. And they're very helpful in pain and shortness of breath in patients with advanced disease of any kind. So whether it's cancer, heart disease, lung disease, organ failure, frailty, dementia, so on, they can be helpful. And prescribed in appropriate doses and in appropriate patients, they are safe medications. In fact, I hope that showing you that patients with access to palliative care live longer, since most of those people are taking medications for pain or shortness of breath, that actually treating symptoms helps you to live longer. And we have multiple studies showing that opioids used for pain and shortness of breath in appropriate doses in people with serious illness do not shorten life. A lot of people worry about addiction with these medications, and certainly if you read in the newspapers, you'll read about people having problems with addiction with these medications and actually taking fatal overdoses. Many of these people have addiction, and they've had it since they were usually teenagers, and there's lots of other factors that have contributed to that addiction, such as genetics. Someone in their family had this problem, the environment, growing up in poverty, and difficult circumstances, and other psychological factors like being abused or having a very difficult upbringing or childhood. So really, if you don't have some of these addiction factors, you're not going to become addicted to opioids. In other words, it's not the drugs, it's more the factors around the person. The other myth that people have is that opioids lose their ability to treat pain and shortness of breath over time. So people are reluctant to use as much as they might need because it might stop working. That's not true. We can always control pain by adjusting the dose or trying different medications and things like that. And one thing that's really important to know is that the response to opioid medications is very individual. So what works for you won't work for me, and so on. And it's really that therein lies the skill of the person who is prescribing the medication to choose the right one and to adjust it appropriately. So how do you access palliative care if you think you need it? Well, most people ask their family doctor about it. You can also ask your specialist doctor about it, and you can also self-refer to your local health unit in British Columbia. Also, some people like to go online and read more and find out more. And you can find out more information at an excellent resource called Canadian Virtual Hospice. And you can see their address on the screen there, and also available is the BC Hospice Palliative Care Association as well. In this section, I'm going to talk about understanding the rights that people have as patients, because I think this is really key to help people manage in the system better and get the care that seems right for them. One of the major principles of patients' rights is informed consent. And this really is that every adult has the right to decide what can and cannot be done to his or her person. We don't do informed consent for small things that are simple and common, like a blood test or an x-ray. We don't go through a consent process for that. But if you were going to have a more complex procedure like surgery or chemotherapy or blood transfusion, you would need informed consent. What needs to be discussed in informed consent is the nature of the condition or the diagnosis that is requiring this treatment, the purpose of the treatment and how it works, the risks and potential complications of the treatment, and all reasonable alternative treatments or procedures should be discussed as well, including, in serious illness, the option of taking no action for the disease and treating symptoms. Or, because I often say, as doctors, we often assume that if someone comes to us, we must want treatment for the disease to try and cure it. A lot of people might say, well, no, I recognize that, I'm nearing the end of my life and I want to be comfortable, I want to have my pain and symptoms treated, but I don't want more surgery, I don't want more chemotherapy. And that is perfectly within your right. And oftentimes this is not raised as an option. So it's perfectly right for you to say, and what will happen if we don't do anything, and what can you do to treat symptoms? So the other thing that needs to be mentioned is the probability of success. And most people tend to focus on how likely is it to be cured, or how likely are they to die from it, sort of the two extremes of, how well will the therapy work. But I would say that sometimes the most important thing is what the patient is hoping the treatment will do for them. In other words, well, I hope it gets me well enough to be able to go out and walk and do my own shopping and et cetera, et cetera. Sort of what the patient is hoping to get out of the treatment, and the probability that they will achieve this. Because sometimes we may say to people, well, the chances of you dying from this surgery are X. But really, you also want to know, well, will this surgery help me return to a normal life? How will my life be after this? So the more complex questions, they're often more difficult to answer, but really they're far more important to the patient in the long run, and they're often not discussed. Now, we do have some exceptions to informed consent, and those are emergencies where the person is unable to consent and we don't have a decision maker available. So car accident with severe injury, but that's pretty rare. Most of the time we do have time to discuss it. People can waive their right to informed consent and have a family member make decisions, and we do see this where someone says, no, my kids are looking after this for me and I prefer you to talk to them. This is not the usual thing. Most people might say, well, yeah, I want to make decisions, but I want to have my son or my daughter there, or I want to have other people there, because having spare pairs of ears and thinkers is always a good idea. So a patient can also waive the right to be informed about what's wrong with them and so on, and leave it up to the healthcare provider's judgment. But they can only do either one, like get a family member to make decisions or the doctor, if they themselves are capable to make decisions, and we'll talk about that as we go along. So even though people may waive their right, they can still ask questions at any time or change their mind and say, you know, I want to know what's going on. So it's a very kind of fluid arrangement that we can have. Now, informed consent includes the right to refuse treatment under any circumstances, even if it results in earlier death. So refusing chemotherapy, refusing radiation treatment or surgery, or treating an infection is always within the right of the patient and is perfectly ethically and morally acceptable if the patient feels that they just won't benefit from this treatment, or the burdens of the treatment are way more than they feel that they can cope with. A healthcare provider must ensure that the patient's aware of all the possible therapies and aware of the consequences of refusing the treatment. Now, it's very important to know that this is not euthanasia or physician-assisted death. This is a perfectly reasonable and rational thing to do, and it does happen in healthcare facilities where people say, no, I've had enough, or I don't want any further treatment, or I don't want any treatment. This is perfectly acceptable. Another part of informed consent is the right to stop or withdraw from a treatment at any time. So people can say, you know, I don't want this feeding tube anymore, or I want you to take me off the ventilator because I'm not going to be able to return to the life I had. I'm going to be stuck in hospital, et cetera, et cetera. All these things can be done. Some people may say, oh, this chemotherapy was way more than I can stand, and I don't feel I'm going to benefit from it. We, again, as healthcare providers, must ensure that the patient is aware of all the therapies and consequences of stopping the treatment. But it's important to know, again, that this is not euthanasia or physician-assisted death. And many times when people say, oh, they've taken them off life support, people say, oh, that's euthanasia. But actually, what it is that the life support may have been prolonging their dying process. And in fact, they never would survive without it. So by deciding to withdraw it, the decision has been made to allow a natural death. And that's where many confusion comes, because we call it life support. And oftentimes it's just death prolonging treatment. And so I would encourage you always to be aware that you have a number of decisions and options to be made, and to speak in detail with your healthcare provider if you feel you don't fully understand what your options for treatment are. So what is physician-assisted suicide? Well, this is where a physician knowingly and intentionally provides a person with the knowledge or means or prescription to end their own lives. So usually the physician would give someone a prescription for a lethal or a killing dose of a medication. The patient themselves takes the medication. So it's called physician-assisted because the physician provides the means for that person to end their life. And of course, it's usually done in the setting of intolerable suffering. Euthanasia, which is different from physician-assisted suicide, is where the physician themselves knowingly and intentionally performs an act that is only intended to end the other person's life or end the patient's life. And Usually this is done in the setting of intolerable suffering, that the person doing this, the physician doing this, knows about the condition and commits the act with the intention of ending the life of that person. So how is this different from stopping so-called life support? It is different because of intention. When we stop life support in someone where they have no hope of returning to a life where they can breathe on their own or function outside of an intensive care unit, we are merely stopping a treatment that is prolonging their dying process. The difference is with euthanasia is often people are at a much greater functioning level. They may know that they have upcoming symptoms and decline in their function and so on, but they do not wish to go through that and will request that they are given a dose of medication to end their life, specifically with the intention to end their life. And it's often not treating symptoms, it's primarily with the intention of ending life. And many of these things get very confusing for people. And again, we have people in the hospital that can help explain things. We also, most hospitals have an ethics team that the patient or family could request to help sort these things out for them, because it can be a very confusing thing, particularly if this is your first experience with the healthcare system. Now, what's changed in Canada is that the Supreme Court of Canada in 2015 struck out a part of the law that prohibited people against assisting in a person's death. And they only struck down the prohibition for a very certain condition, that is a competent adult person who clearly consents to the termination of life. The less certain thing is under what circumstances. So they did not say that you needed to have an illness that was going to end in death. They did say that you needed to have a serious or grievous and unfixable or irremediable medical condition, but that could include illness or a disability. That this illness or disability needed to cause enduring suffering that's intolerable to the individual in the circumstances of his or her condition. And that irremediable means that if it's not, the patient themselves is the person who determines what treatments they can accept and go through and what treatments they can't. So irremediable could be a condition that is potentially curable or manageable or treatable, but the patient does not desire to go through the therapy that might be involved in that treatment. So sorting all this out over the next while is going to be incredibly challenging for people, and it will probably complicate things a little, but I think what I would say is that you need to sort of think about how you feel about these things, and let your doctor know if you're the kind of person who say, I might want that, I might never want that, and so on. And these things are all, again, there are people within the hospital who can help to discuss these things. So I want to talk for a little bit about capacity to make decisions, because we did talk about the Supreme Court decision needing to be a capable or competent adult. And what that means is that you actually have the means to decide and understand all the complexity of the illness and then to make a decision. And as you can imagine, you need a different level of ability to think and reason depending on what you're deciding on. So if you need to decide what to wear today, that could be simple. Where to live, but whether to have a treatment for a life-threatening illness, you can see that that's way more complicated than deciding what color you're going to put on today. And the 4 key principles of capacity to make decisions is that the person understands the medical situation, so they understand what problem or condition they have. They understand all the options for treatment, including the option to just treat symptoms and allow the disease to take its natural course. That this person can explain why one option suits them better than all the others. And this will be an individual thing. And that the person is able to express a choice. They don't have to necessarily speak it, but they have to be able to express a choice. And so if someone meets these principles, they are capable. Now, we tend to assume that a person is capable until proven otherwise. So you don't have to go through a test every time you have a discussion about a treatment with someone. It's really that if things occur that make us wonder whether you're capable, then we may be asking you to explain some of these things. So what if you're not capable? And by the way, many people will, as they get more frail, as they get older, as they get sicker, will be less capable of decision making. And if a decision is made that you're not capable, we would look for someone who's close to you to be a temporary substitute decision maker. If we're looking for someone, if you're seriously capable and it's seriously incapable, and you really can't even think what to wear, you need clothing, you need someone to look after your housing and your shopping, etc. Then we tend to get you a comitative person, in other words, someone who's responsible for the total care. The other option that is available for people is that earlier, when they are capable, they can say, you know, I want my nephew to make my decisions, or I want my best friend to make my decisions. And this is called a healthcare representative, and we'll discuss that a bit more. A temporary substitute decision maker must be at least 19 years of age. They have to be capable of making the decision themselves. They have to be in contact with the patient. So you can't say, you know, my son will make the decision, but you haven't seen him in 5 years. That doesn't work. The person has to have a dispute with the patient, otherwise you can imagine there would be a conflict, and they have to be willing to do it. So who can be a temporary substitute decision maker? Well, the government has a list. Spouse, child, parent, brother, sister, you can see it up there on the screen. And then new ones that have been added are grandchild, grandparent, any other family member, a close friend, related by marriage, and then if nobody is available, we will go to the public guardian and trustee, but they usually try and appoint a friend or something. So if you, for example, in my own situation, I have a spouse and I am content with the spouse making my decisions. So I am going to leave that as is because I'm content with that, or my children making decisions if I'm unable to. If you're not content with this, you would want to have a healthcare representative. And that is a person that you can legally name as making healthcare decisions. Obviously, they have to agree with you and be willing to do it. They have to be an adult. You need to do this in writing. It has to be notarized. And you have to do it when you're still capable of making decisions. I put a website down for British Columbia that gives you all the information about doing this. And for many people, they like this because their family may not understand their wishes and needs, or the family may feel that it's too much of a burden and they may want to ask someone else to do this. Oftentimes we talk about advanced care planning, and we've been encouraging that a lot in British Columbia, and I think it's a good idea for everybody who is capable and is thinking about the future to think about their wishes, values, and beliefs, and instructions for healthcare at a time when you may not be capable. It really is an ongoing conversation with your family or your healthcare representative and your healthcare provider, because although you can name somebody and say they'll make decisions for you, you need to give them some kind of guidelines, about what kind of decisions would sit well with you. And rather than be a sort of like a menu or a checklist of treatments you will and won't have, that can be very difficult. It's really about, what is really important to you, like saying, I really want to be able to live on my own. I want to live as independently as possible, or I'm okay with, moving to a place where I can get help and so on, and I'm willing to accept a fair bit of disability, or, I don't want to be disabled. These are the kind of things that you need to think about, and they're going to change over time. And we know that they do, and typically when people are well, they tend to not want any disability or illness. But when things change, most people find, hey, this is not so bad. I still have a good quality of life. And so things change over time. So it's an ongoing conversation. And I put 2 websites up there. One is a general Canadian advanced care planning website, which is very good. And also the website for British Columbia, which has an information booklet that you can read. I would also strongly recommend that you look at the videos, because a lot of people find the booklet to be very long and complicated. But the videos are much shorter and easier to watch. So the last thing to think about is if you're receiving palliative care, or if you have a serious illness, how do you know if you're receiving palliative care and if you're receiving good quality palliative care? Well, you should be able to think through the following things. Your symptoms should be well controlled. If they're not, you need to let your healthcare providers know. You should also be able to understand enough about your disease that you're content with that amount of information. And if you need more information, it's your right to know. If you want less information, it's also your right to tell people that you don't want to hear about too much. You should be able to understand what your doctor's saying to you and should feel free to ask questions. You should also, if you're needing it, allow and receive community support to help you stay at home as long as you can manage. And I specifically put down allow because I find many people say, oh, I've got my family or I've got friends to do that. But allowing them in and supporting you and accepting the services that we have can help you to stay at home longer. And it also makes it a lot easier on your family. You also should be allowing and receiving support to help you cope with the illness both mentally and spiritually. And healthcare providers can't do all of that. Sometimes that's your friends. If you have some community support people, or if you have a faith, reach out for support that can help you cope with this. The other last thing is that you've spoken to your family and your doctor about what's important to you and your hopes and your goals, so that if you can no longer make your own decisions, people know what to decide on your behalf. So thank you very much, and I hope this talk has been helpful for you. I think by overall the best Website for finding out more information about palliative care is Canadian Virtual Hospice, and do check it out at www.virtualhospice.ca. Thank you very much for your attention.